done a good work, and all of us know that he has published a very good book on the pediatric musculoskeletal infection, and he's also working on another book on skeletal dysplasia. Without wasting your time, I will hand over to Dr. Mohan, then we'll go for the case. What do you want to say something? The format of this session today, we will have a few introductory remarks from Dr. Mohan, then we will have the 4 case discussion. Each case is 8 case presentation for 5 minutes and 5 minutes discussion and question answer. So each case will belong to 12 minutes, 12 to 13 minutes. So we will finish all the case discussion in 50 minutes. Any other question, any other fellow? Most welcome. They can share their ideas and queries with the experts. Thank you.
Thank you and good morning, everybody. Thank you for having me and giving me the opportunity to learn from you all. So I was thinking we discussed yesterday. So Hitesh has kindly provided 4 very interesting X-rays to talk about. So we're going to present. I think he has already allotted people. So you're going to present the case and give us a problem list and your solution. And then we are going to kind of talk about it, have a discussion and see if that solution is okay or it needs to be fine-tuned, or if there are any alternative solutions depending on the team's expertise, the surgeon's expertise, and the family circumstances. And then hopefully that will allow and create some good learning opportunities. So let's move forward with the cases. Thank you.
Yeah, thank you. Mohammed, can you share the first screen on the first case? You can share the screen and present.
Yes, sir.
Yeah, go to the full screen. Yeah, thank you.
Okay, thank you, sir. So the first case, he is a 11-year-old boy. He presented with a painless limb for 3 years, and he had a history of NICU admission, and there was no history of any surgical treatment so far. And the clinical examination wise, he is having a reasonable range of movement, and it's not painful. And he is having right-sided shortening of 1 centimeter. With the X-ray, I started measuring with the neck shaft angle. I got the right side 150 degree and the left side 145 degree. And articular trochanteric distance, I found it is reduced on the right side. And medial proximal femoral angle anatomical, it's reduced in the right side. It's around 60 degree, and in the left side, it's around 85 degree. And acetabular index is right side is 18 degree and left side it is 28 degree. And about the limb length discrepancy, right now he is 11-year-old child and having the LLE of 1 centimeter. When I am multiplying with the multiplier of 1.24, expecting an LLE at maturity around 1.24 centimeter. And the problems I found in the right side, there's a shortening of neck, coxa breva is there, and so there will be a decreased abductor lever arm due to the coxa breva, and proximal femoral growth plate arrest, longitudinal growth plate arrest, probably due to the secondary to the facial arrest laterally, more laterally, and there is an overriding of trochanter, and there is a decreased articular trochanteric distance. And the coxa valgae is there, an exaptic angle of around 150 degree, and decreased medial proximal femoral angle of 60 degree. Femoral head is non-spherical and it is more flat, and the shortening of 1 centimeter. There is a femoral acetabular impingement and increased medial joint space. On the left side also there is some changes in the X-ray. Like there is a coxa valga, mild hip is subluxating, mild subluxation is there, and epiphyseal height is decreased. There is a medial joint space, so joint space reduction is there, and the teardrop is wide, and acetabulum is the acetabulum is more of shallow. These are the other views, X-ray views, and my this is the full stitch view for the measurement of the LLE. And the problems I found in these X-rays are that's a shortening of neck, and there is a LLD is there, trochanteric overriding with requisite ATD and femoral stable enlargement. And for the shortening of neck, I would suggest the options are relative neck lengthening, true neck lengthening procedures like Morses, and FA is severe if it is clinically, if it is there, we can go ahead with the osteochondroplasty. And the trochanteric overriding we can address by doing an trochanteric transfer. LLD, I think we don't need to do an intervention right now, because if you are doing a true neck lengthening, it will gain a adequate length in the affected limb right side. So I'm planning like a preoperative planning with a templating. I'm planning to do a 3-level osteotomy, Moses osteotomy with just above the neck one, and another osteotomy at least 1 centimeter above the first, and the third osteotomy below the neck and parallel to the neck screw or blade. And the implant of choice, I have 2 choices, like a PHP system, pediatric hip plate we can use. Since the child is a little big, I am preferring to use the 5mm system, and or I can use the foramen plate. So the procedure goes like we have to check with the final how much I'm targeting the final neck shaft angle, and select an implant and mark the osteotomy sites, and we have to find out the length of the blade or neck screw by considering the lateralization of the shaft, and transfer of the trochanteric fragment for augmenting the neck length, and the GT distalization for the overriding of the greater trochanter. And the procedure I'm planning first, like I want to decide about the final length of neck shaft angle. So I'm targeting around 130 degrees. So I will measure the angle, the neck screw length, or if you am using the blade plate, I will measure by considering the length, which is I want to increase in the length. So I will take a fragment from the trochanter that I will use laterally. So these are the osteotomy sites I am preferring to use. Just once, the first one just above the neck and parallel, and the second one at least 1 centimeter away from the first one, and the third one just below the neck, parallel to the my screw or blade. So here I am trying to use the PHP system. So the PHP system, I'm trying to use the 130 degree angle. So the screw will be going like this, neck. So the fragment from the trochanter, I will be transferring into the lateral aspect of the neck, and which incorporate through the neck screw. And I am doing a osteotomy just above the LT that will help me to lateralize the shaft, the distal shaft, and the trochanter, rest of the trochanter, I will utilize for the distalization. So it will be coming like this. So the distalized trochanteric part, I will be preferably fixing with the K-wire or screws with the tensioning by using a SS wire. This is my planning, sir.
Good. Good
Anything
job.
you want to
Let's
do
go
for
back to
lateral?
the AP X-ray.
Okay, sir.
Okay. So I think you, yeah.
Sorry. Yeah.
Yeah. Thank you for your presentation. Very nice presentation. I think you identified most of the things, but I think work and couple of things you could identify was, this on the AP, you see the sagging rope sign. Does everybody see it here?
Yes, sir.
This here and this here. So what does that tell you? Anybody? I think you said that he has femoroacetabular impingement, and then if you go back to the lateral X-ray, this tells you that the head is not round. It
Yes.
tells you that the head is now, he's got coxa magna as well as it's a mushroom shaped head. So you can see that this is the cause of the sagging rope sign. Okay. On both sides, he has it. Okay. And then go back to the AP X-ray again. The other important thing is, this what we call the caput valgum. That means the femoral epiphysis in relation to the neck, not just the neck shaft angle. Sometimes you have to evaluate the relation of the epiphysis to the neck. You can see the epiphysis is in valgus. Okay, that usually results when there is a type 2 growth arrest of the proximal femoral growth plate. That means the lateral part of the femoral growth plate is shut down or growing slower compared to the medial part. Okay, so you did identify that there was a growth arrest of the proximal femoral growth plate. I'm not sure it's completely closed though, even though this X-ray shows the appearance of that. And then, so those are a couple of things I identified. And the second thing is there's some incongruity between the femoral head and the acetabular joint surfaces. So that's another third thing. You can do all these fancy reconstructions, provided the femoral head is nicely reducing into the acetabulum. Okay. So those are three kind of additional comments that I wanted to make in addition to what you said. And if you go to the mechanical axis view that you showed earlier, you identified leg length discrepancy, but he also has some varus in the distal femur there. If you draw the mechanical axis here, you'll see that he has some varus. I think it's probably coming from a distal femoral growth arrest. I can't see it very clearly, but I'll probably think about that because proximal tibia seems okay, but if you draw the mechanical axis, it's in varus. So that's another problem you need to think of. Obviously, it's not crucial for hip reconstruction, but you're giving an overall plan for the child. So, and then another thing you might want to think about is you need to understand as a pediatric orthopedic surgeon, you want to understand, I feel that you are a gardener, not a carpenter, like the adult orthopedic surgeons are. So a gardener means you put a seed in the soil and you need to know what kind of tree you're going to get. So you need to be able to have this crystal ball in your hand and be able to predict what's going to happen to this child if I do something now. Okay. And in order to do that, it's important to understand the natural history. So what do you think was the cause of this hip condition? You didn't kind of touch upon that. You did say that he was admitted in the NICU when he was a year old. He didn't have any surgery and he must have had some treatment because he wouldn't have been admitted to the NICU with no treatment. Okay. So, and what was the cause of these problems in the hip? What do you guys think? Is it DDH? Go ahead.
It can be a post-septic.
Okay. And why do you think it's post-septic?
He's giving a history of an NICU admission.
Okay. Well, I think you need to get more into the history, right, in order to kind of make that more clear. Because just NICU admission doesn't tell you it can be septic hip. It could be, but it could also be that he might have been admitted in the NICU for other reasons too. Or it could be like somebody is pointing out DDH, but if he's had no treatment, usually this is a result of iatrogenic treatment causing these things. So usually if he's not had any treatment, it's less likely to be DDH or post-DDH sequela. What do you guys think? Hitesh and Dhiren, I think Dhiren's raising his hand.
Yeah, just I would like to ask you a question. Like you said that there is a sagging rope sign. So what is the cause of it? And secondly, how does it help us in decision making?
Yeah, I mean, sagging rope sign is a radiologic sign that indicates that the femoral head is asymmetric, not just in one plane, but in the sagittal plane as well. And it helps you in understanding that because you're looking at a one-dimensional X-ray and trying to make a decision on a three-dimensional structure. So it's very important for you to understand the geometry of the femoral head. Obviously, you will have two-dimensional X-rays, but even then, that doesn't completely give you the whole picture. So this tells me that in addition to coxa breva, he also has coxa magna, and in addition, and there is asymmetry of the femoral head. So if you don't take that into account, you might create some secondary problems down the road. So, and also it helps me to say that, like in your treatment plan, you didn't identify like surgical dislocation of the hip. Obviously, you need to next know, I think it's a post-septic hip, this one. And then secondly, you said he didn't have any pain. The other thing from the examination that's not clear is whether he has any impingement. When you do like flexion, adduction, internal rotation, whether there is anterior impingement, whether there is lateral impingement, or whether any posterior impingement. So that you need to differentiate based on the examination. And we need to understand more about the function of the child. Like what is you can't say range of motion is reasonable, because when you're planning these osteotomies, you need to know exactly how much abduction, how much adduction, how much flexion, extension, and rotation there is. We can't just work on being reasonable. We have to have clear numbers. So I would encourage you, I know like this is somebody else's case, but I would encourage you to kind of document that before planning any of these osteotomies, because we orthopedic surgeons look at x-rays and treat, but we need to look at the soft tissues, because there are soft tissue considerations. If he has like an abduction or adduction contracture, then creating varus and valgus might decrease that range later. Or you may need to correct rotational alignment. So those are some things that I would suggest that you guys do. But my plan would be, I would do like a surgical dislocation, and you didn't differentiate between right and left sides, because in your plan you need to clearly say like, yes, the plan you showed seemed more like for the right side, in my understanding, but you didn't clearly say that. Okay, so in this case,
Yes,
both hips
right.
are problematic. And then there's one other piece of information that I want to allude to before we decide on treatment. Go back, I think Hitesh has provided abduction, internal rotation x-rays, because on the left side, if you can see, the joint is incongruent because there is narrowing of the joint space. So, but the abduction, internal rotation x-ray seems like the position improves, especially on the left side. It's becoming a little bit more congruent. So when you're faced with these asymmetrically incongruent hips, so this is a concept that Tony Catterall from UK kind of brought about, like symmetric and congruous. What that means is how the shape of the femoral head relates to the shape of the acetabulum. Okay, are they equally round or not? And then are they congruent? That means is the joint space symmetric all around? Okay, so those are a couple of concepts. In this case, the head is not spherical, but at the same time, so there's some sort of discrepancy between the acetabulum and the femoral head. But it seems like on the left side, it's more symmetric and congruent in that abduction, internal rotation X-ray. So you want to do this when you're planning, especially on the left side. There's also acetabular dysplasia. You want to see if you're doing a femoral osteotomy and want to improve coverage, you may require a pelvic osteotomy on that side. So to do that, you want to make sure the femoral head is in its most congruent position. So you may want to take this child and do a fluoroscopy or Shyam valuation in different positions to see, which is the best position for the femoral head. So you do abduction, adduction, internal, external rotation, flexion, extension, or a combination of that to see like which is the best position that the femoral head sits in the acetabulum. That can help you kind of plan as well. Okay. So in this case, I might request an MRI just to look at the femoral growth plate on the right side and look at the acetabulum and also the femoral head on the left side to get a little bit of a better understanding. And definitely I need an MRI of the right knee, you look at the distal femoral growth plate on that side. Okay, so those are my investigations and then other tests. And these days, where you have like 3D reconstruction and things like that, and this is a complex operation, you may consider doing like a 3D reconstruction with a, femoral head anatomy so that you can simulate your osteotomy and plan it out better. Not that I'm not saying you have to do it for every case, but you may consider doing it if you don't do this frequently, or like this is your first case, something like that. Any comments you guys want to add, Hitesh and Dhiren, before we go to the next case? Sorry, before you go to the solution.
Yeah, I agree. And I got into one of the comment from Dr. Anil is there. We need to consider our articular cartilage, whether it is healthy or not. That also we need to consider that. Second part is that I want to focus one more comment on that. The right side is subluxated. So the true lengthening, there are two different type of the neck lengthening. Actually, the Wagner osteotomy is different, and then Moscow's osteotomy is different. So when you check about the congruency, I like to say that whether it is possible to do.
Hitesh, we can't hear you.
Oh, sorry. Whether it is now, is it okay?
Yes,
Yeah.
yeah.
Yeah. So whether it is congruent or incongruent, we need to decide before or preoperative. We can do about arthrogram and decide. And the best position we can do about the osteotomy. Along with that, we need to separate out the extra-articular problem and intra-articular problem. Intra-articular impingement and extra-articular impingement. And if possible, we can deal with both. But as a one hip at a time. I agree with you entirely on the right side, on the left side. Any other question from any people?
Yeah, so let's go back to the AP X-ray. So in this case, you will have to make a shared decision making with the family and tell them that both hips are kind of not great, and then depends if I'm sure he'll probably have symptoms. If you're saying he doesn't have any pain, it's kind of hard for me to kind of know that, but he probably will have pain based on the appearance of these hips. But you'll have to make a decision with them, tell them if he's not painful, that you're trying to preserve the life of this hip for the long term. That's the purpose of the operation. So my solution would be, if you want to go back to the AP X-ray. Yeah, so my solution would be like a safe surgical dislocation, and then a trochanteric osteotomy, and then surgical dislocation followed by osteochondroplasty. I am not going to do like an Marshall osteotomy in this case because the femoral head was sitting better in abduction. So I would probably just do a varus. And then I saw Anil Agarwal's question about how are you going to deal with caput valgum. I think there's two ways of dealing with it. One is, you could do like Gans talks about doing a secondary femoral neck osteotomy, then to realign that, or you could stop the growth plate. You could prevent it from getting worse, because when you're creating varus, that will to some extent address it, but to prevent it from getting worse, you could stop the medial side of the growth plate. Those are two options. And then after doing the femoral osteotomy, I don't think this requires an acetabular osteotomy on this side. And then you'll need a distalization and the lateralization of the trochanter. And then I'm happy using a blade plate. So if I have residents with me, I'll use a cannulated blade plate. But if you want to use a proximal femoral locking plate, that's okay. The other thing to calculate on this is how will you put your guide wires for the correction. So for that, it depends on what is the desired angle of correction from valgus to varus, and then what is this angle of the blade plate you're using. So those two things will give you the angle at which you're going to insert the K-wire. So that would be my solution. The rest of it, I agree. The trochanter you're going to put a screw tension band wire, that's fine. Those things are good. On the left side of my solution would be against surgical dislocation, osteochondroplasty, great trochanteric osteotomy, osteochondroplasty, relative neck lengthening, varus, maybe derotation osteotomy. But I think the child is going to need a Bernese triple because the triradiate cartilage is still open, so you can't do a PAO. So I would do a Bernese triple for that. What do you guys think?
That would be the good plan. Should we go for the next case?
Sure, unless if anybody has questions.
Yeah, otherwise we'll have the only discuss only 2 cases because it's already 7:57.
Yeah, that's fine.
Yeah. Thanks. Devendra, can you share your screen? Put on second screen. By the time we can talk 1 minute, any question from anybody?
Yes, sir.
Yes, go
Am
ahead,
I visible,
Devendra.
sir? Yes, sir. So
No, we can hear you.
Yeah, yes, sir. I'm presenting the case of 2.5-year-old child.
Can't see
who
the
came
screen.
with,
Share the screen. We can't see the screen. It's not visible.
Okay, sir. Yeah.
Share the screen.
Yes, sir.
Yeah. Yeah. Well, full screen and start
Yes, slideshow.
quickly.
I am presenting a case of a 2.5-year-old child who presented with painless limp, and this is the X-ray on presentation. And the child underwent bilateral open reduction, varus derotation osteotomy at 4 years of age. Implant removal was done at 5 years of age. So she again presented at 8 years of age, and this was her picture. So we can see that there is coxa valga clearly, and there is also a caput valgum, and acetabular index is reduced on both the sides, and center-edge angle of Weber is also less than normal, that of 25 degrees on both the sides. And if we calculate the Reamer's migration index, it is around 50% on the right side and around 40% on the left side. And she is asymptomatic as of now, and she presents to the regularly clinic for follow-up. The range of movements of both the hips are painless, and there is no limb length discrepancy. So if we draw the mechanical axis, we can see that there is a mechanical axis deviation of, and it is in -2 station. And these are the various problems in which I have recognized. There is the Shenton's line is broken on the right side, and there is acetabular uncoverage, as I mentioned, and there is a Reamer's migration index of 50% on the right and 40% on the left. And the center edge angle is less than 20. Acetabular index I have mentioned is less. And there is caput valgum and coxa valga. So these are the various problems I have identified. And my solutions are, I would offer the child a medial transfascial screw fixation on both the sides, and or a subtrochanteric varus derotation osteotomy. And in intra-op, I would check for acetabular coverage, especially on the right side. And if the femoral head coverage is inadequate on the right side, I would proceed with triple innominate osteotomy on the right side. So between the two possible solutions of medial transfascial screw or subtrochanteric varus derotation osteotomy, the physis on the lateral aspect of the femoral head should be growing for this technique to work. So more dependable in this situation, I would suggest is a subtrochanteric varus derotation osteotomy. And as I said, if intraoperatively, if I have the femoral head coverage is still not adequate, I would do a triple innominate. Yes, sir. Thank you, sir.
Yeah. So good presentation. So, and then you were able to pick up the genu valgum at the knee. A couple of things. Do you want any other investigations that you want to do? What is the reason for caput valgum in this case, post DDH, post surgery?
Sir, it probably was avascular necrosis, which caused fascial arrest on uh, the the lateral side, and that is why we are getting this picture of caput valgum.
Okay, so if you just and then the medial transfacial screw is not going to work because if you put it medially, there is no epiphysis there. So you won't get any screw threads.
Yes, sir.
You can
Yes,
see
sir.
because the head is all lateral. If you put a medial
Yes,
screw,
sir.
it's going to sit in the physis. It's not going to go anywhere in the epiphysis. So it'll be in the joint. So that's another problem you also face in children with cerebral palsy when you have this problem because the, uh, this is a difficult problem. So and then the subtrochanteric varus osteotomy will correct it, but how will you prevent recurrence? Because if you don't address the growth plate arrest, which is probably partial here, it'll recur over time, right? So you need to consider those things. So and then if you go back to the abduction internal rotation view, that was showing that femoral head was getting contained, better.
On the left side.
Definitely, there is still some acetabular dysplasia there. Okay,
Yes,
so yeah, I think you identified most of the things. I would still want an MRI to look at the growth plate here to understand better the this thing, and also like a CT with 3D reconstruction because to understand the anatomy and where the uncovering of the acetabulum is or where the acetabulum is shallow. Most likely it's anterior lateral, but I would still want to get an CT. And then
yes, sir.
I would agree with your plan. Go back to your solution.
Yes, sir.
You said, yeah, so I would probably do a varus derotation osteotomy. And then I would probably complete the growth arrest, not with a screw or something, but you'll have to complete the growth arrest of the femoral neck growth plate to prevent recurrence. Or, like I said, you can do a second osteotomy in the femoral neck to correct that at the time. And then I think on both sides, you will need an acetabular procedure. Because the triradiate is open, I would probably end up doing some kind of acetabuloplasty, like Pemberton or Dega type. I don't think you will need a Bernese triple in this case, but you wouldn't be wrong if you wanted to do that. But I don't think you need to redirect the acetabulum. I think you just need acetabuloplasty. I think here. Any comments, Dhiran and Hitesh?
Yeah, I have just one point. Do you think so? The MRI would change our plan?
Most probably not, but I would like to know a little bit better about proximal femoral growth plate.
Okay. Would you combine both together? Both sides?
Sorry?
Would you combine both sides together or one by one?
No. One side at a time.
Yeah, it's okay. That's fine. Any other question from anybody, Dhiren bhai or anybody, or we can go for third case?
Yeah, just to like tell the residents like why you don't want to combine two sides together. Is it the magnitude of surgery which is the reason or something else?
Well, first of all, these are both are difficult hips. So you want to do a good job. You don't want to be rushed. Second thing is, the child is small. About blood loss, you're operating both on the femoral side and the acetabular side. So in my hands, it'd probably be 200 or less of blood loss, but that's one of the things because I don't want to transfuse the child if at all possible. I mean, if you are doing both sides, then I would use a cell saver. Not that I've not done it like in children with cerebral palsy and things like that. I always do both sides at the same time, and I have done both sides. But in general, especially when you're starting off in practice, it's better to do one side at a time. You're not rushed because these cases sometimes can take a little longer. But yeah, there's no harm in doing both sides. Like you can do both sides, but you probably need like 2.5 hours or so for each side. So you must have that kind of time. And if you're doing both sides, I would consider using like EXA, and then cell saver. Let the anesthesiologist know after you're done with one side. Check with the anesthesiologist. Consider doing an epidural if you're doing both sides or even one side for post-operative pain relief. And Anil Agarwal was saying, is the plan the same for both sides? I don't think you need to. There's not much of caput valgum. There's a little bit of it on the left side, but not too much of it. So that's another reason why the MRI is going to help me to decide on the left side. But probably to maintain symmetry, I would, if I'm doing a complete growth arrest on the right, I would probably do the same on the left, just to prevent leg length discrepancy in future, and also to restore symmetry. And I think there's a little bit of valgus, caput valgus there, but not as bad as the right side. Yeah.
Thank you.
Yeah.
We'll
Does
go
that answer your guys' question?
Yeah,
Yes.
and we'll go for the next case. The next case, Akash, you can share your screen. Devendra, you can stop it. By the time, we'll ask one more question. Is derotation needed in this case, and what is the indication? How much to do?
I think that depends on clinical exam. This is where the CT torsional profile is going to help, and also your clinical examination, like Staheli's rotational profile test. I use Staheli's rotational profile test a lot more, and also I do, because I have gait analysis. I also do dynamic evaluation of the child, and then look at that before I do any rotation. So I correlate. So the static exam is important, and then the CT with torsional profile will give you in these complex cases. That's why you need a 3D reconstruction to tell you what is the rotational profile. And then third thing is, if you have gait analysis, or even if you have 2D gait analysis, you can use that information as well to kind of incorporate that into your decision making.
Okay, just a quick
Does that
question.
help?
Yeah, if the torsional profile and the rotational profile on the clinical examination, if they don't match, which one will be more important, the torsional profile CT or the clinical examination?
I will then look at the dynamic rotational profile. So that's what is important,
That's a
because you're
clinical.
Yeah. Well, when the child is walking, not static exam, because essentially you're using your hips to walk. So we want to restore the dynamic alignment. So sometimes they are different. I can tell you, because either it's inaccuracy of marker placement, or it may be because of inaccurate exam or interpretation by the radiologist. So sometimes I go down, check with the radiologist, make sure the lines are correct. And then, yeah, so those are things I'll make sure before, but I will always go by the dynamic evaluation.
Yeah.
You can also do an examination under anesthesia when the child is asleep. Yeah. Like Hitesh said, you can do an orthogram, make sure the head is perfectly congruent before kind of committing yourself. Yeah. I always do an examination under anesthesia. Sometimes with orthogram, if I can't see the whole of the femoral head, or in skeletal dysplasia cases where the epiphysis is not completely ossified, you get the correct information, and you're doing a dynamic examination before you're committing yourself.
Okay.
Thank you. Akash, can you present? Yeah.
Good evening, everyone. So this was the case given to me. 10 years old child, old case of left-sided Perthes disease. Age of onset was 6 years, and the child was treated conservatively. Child has pain on prolonged walking. However, the range of motion is painless, and the child has frequency of 1.5 centimeters. So on measuring the neck shaft angle on the left side is decreased. It is 118 degrees, and on the right side it is 133 degrees. The medial proximal femoral angle is on the right side it is 89 degrees, and on the left side it is again decreased. It is 64 degrees. And articulotrochanteric distance is also decreased on the left side. On the left side, the apex of the articular surface is almost at the level of the trochanter. And limb length discrepancy, presently it's 1.5 centimeters, and predicted, assuming a complete proximal femoral physeal growth arrest, is 3.9 centimeters. So the problems we are facing here is coxa vara, limb length discrepancy. There's coxa magna. Also, there's the cam type of morphology of the femoral head. There is acetabular dysplasia. It's a shallow acetabulum. There's a short femoral neck, and because of the decreased articulotrochanteric distance, there's also a decreased abductor lever arm, which is an inefficient abductor lever arm. So the possible solutions, for if we look at each of the problems in like individually, for a coxa vara, we can do a valgus osteotomy or a Morser osteotomy. For a limb length discrepancy, again, a valgus osteotomy will help to gain length. Morser osteotomy, or like if there's a complete proximal femoral physeal growth, there is a growth modulation of opposite distal femur at appropriate age might help. There's a coxa magna, which can be addressed with surgical dislocation of safe surgical dislocation of hip and osteochondroplasty. And the same goes for the cam morphology. And the acetabular dysplasia can be addressed with a PA or a shelf augmentation. The short femoral neck can be addressed with a relative neck lengthening or a Morser osteotomy, and the decreased abductor lever arm can also be addressed by the same. However, to try to address everything in a single procedure, my plan would be to go for a Morser osteotomy through a safe surgical dislocation approach. And so this helps us in addressing both the intra-articular and extra-articular problems. This is the X-ray, not our X-ray, but not the X-ray given to me, but the X-ray from the article I showed earlier. So the plan was something like this: to first we'll do a safe surgical dislocation, and we can do a osteochondroplasty. We can visualize the articular surface and do a osteochondroplasty, and then so this is the trochanteric wafer, and then we take another bony block from the base of the trochanter, and then we do a subtrochanteric osteotomy, and we can ideally, the implant I would prefer is a 130-degree angled blade plate, and we can impart valgus to the neck fragment with the help of the 130-degree blade plate, and following that we would lateralize the shaft, place the bony block from the base of the trochanter, and then place the trochanteric wafer on top. Like this bony block, the angle plate will pass through this bony block into the neck, and on over that we'll place the trochanteric wafer, which we'll fix with a screw or a SS wire, stainless steel wire. And this is somewhat illustrative of what the final picture would be like after doing the osteochondroplasty and combining it with a Morser osteotomy. Yeah, so that would be my plan for this case.
What about leg length discrepancy?
Leg length discrepancy, sir, when we are imparting valgus to the neck fragment, we'll gain some length, sir.
Yeah, but your blade plate is also going through the physis, proximal femoral growth plate. So you lose some length there, and you're not going to get back 3.9 centimeters is what you determined.
Mm-hmm.
Yeah.
So
As
we
your
can like we can do a opposite distal femur like in consultation with the parents, like regarding the final height and everything, we can decide on a opposite distal femur growth modulation or an ipsilateral lengthening based on their preference.
Okay. Yeah. Good presentation. And then you've done good work on trying to create the operation. That's good. So like Churchill says or used to say in Second World War, like if you fail to plan, you plan to fail. So that's good. So you did some mental gymnastics and some physical work. So it just helps you think deeply about the case. So that way, you can solve some of the problems that you may face intraoperatively. And another good thing I would say is there's no harm in if when you're starting practice to ask another senior surgeon to check your plan or even stop with you to do these cases to start with or do these cases together because you'll build your experience when you're doing these difficult cases. So let's go back to the AP X-ray. I think you got most of the things. One thing I just wanted to say, I think you did also mention it, is understand the height of the child as well. Because when you have a leg length discrepancy of 3.9 centimeters projected, you want to, you don't want to assume you want to shorten it in all the cases. Because if the child is already short, you may want to lengthen or not. You may want to, the family don't want to lose the length or
Yes.
may not want to lose height. So always check that. And I think you mentioned that. So that's nice. And I like that in the solutions you discuss various options, but you finally came up with your own plan. That's important when you're going for exams and things because they want to know what you are going to do, not what solutions are available. So that's good. So, and then the other thing I wanted to share, which you pointed out nicely, was the difference between the medial proximal femoral angle and then the neck shaft angle. When they are both equally decreased, then whereas valgus osteotomy will correct both of them at the same time. When they are not equally reduced, for example, in this case, I think the neck shaft angle was off by about, I think 18 degrees or maybe 17, 18 degrees.
Yes.
And then the medial proximal femoral angle was off by a little bit more, I think 25 degrees or so. So there you can see that there is a discrepancy. So if you just do valgus osteotomy of Wagner, then that won't correct that. While that may correct the neck shaft angle, it may not necessarily correct the medial proximal femoral angle. So that will be corrected by the distalization of the greater trochanter. That's one thing. The other thing I want to point out is difference between Marshall and the valgus osteotomy of Wagner, because the acetabulum is a little bit dysplastic here. So if you do a valgus osteotomy, it's going to uncover your femoral head eventually. So it'll make it such that you'll have to do an acetabular procedure. But if you don't want to change the orientation of the femoral head to the acetabulum, then that's where the Marshall osteotomy is helpful. Okay, so when you're trying to decide between Marshall and then Wagner osteotomy, one of the things that helps you decide that is whether when you do a valgus osteotomy, you're changing the orientation of the femoral head in relation to the acetabulum. Okay, and you will always end up uncovering it. Okay, especially in the presence of already existent acetabular dysplasia. When you do a Marshall, you don't change the orientation of the femoral head with the acetabulum. You just change everything below it. You just leave the femoral head sitting as it is. So when you have this borderline acetabular dysplasia and you don't want to be on the acetabular side, then you may want to choose the Marshall osteotomy. Okay. So that's one thing that helps me. But otherwise, I think you got most of the things. So safe surgical dislocation, I would do that. I would do a trochanteric osteotomy. I would definitely do an osteochondroplasty because you can see the sagging rope sign here. The femoral head is asymmetric. So that'll help. And then you can do both a relative neck lengthening as well as a true neck lengthening here, because you'll do a Marshall osteotomy to restore the neck shaft angle. I would go for the Marshall osteotomy, and then you'll do the distalization of the trochanter. And then the relative neck lengthening will also give you a nice neck offset. And then after doing all that, once you fix the femur, make sure you can either do a distal femoral epiphysiodesis on the opposite side to restore the leg length, or you may consider later lengthening of the left side, whatever the family wants. Or you can just use a shoe lift. Those are the three options for that. But don't also check the relation of the femoral head and the acetabulum once you're done with the femoral side, because there's a little bit of acetabular dysplasia here. Because there's coxa magna, the femoral head is a little bit bigger and it's already uncovered here. So you may need to look at that and see. You may want to get an abduction, internal rotation, X-ray as well, intraoperatively or before, to see how the femoral head sits in the acetabulum. So you may need to do an acetabulum of this in this case. Any of you want to add anything else?
Yeah, I agree with your plan.
Very good plan.
Yeah. We go for the last case, and because we have 8 minutes to go.
No, we can overrun a few minutes. That's fine.
Yeah. No, the last. Yeah, at least he has prepared well, so I think all 4 should finish. They should not left behind anybody.
Yeah, Kishmita, please.
Yeah.
Good evening, everyone. My case is a 14-year-old male who presented with the painless walking. And on the left side, the external rotation deformity was 25 degrees with restricted abduction and internal rotation, and a limb length discrepancy at present of 2 centimeters of shortening on the left side. These were the AP and the frog leg lateral view of the patient, where we see a decreased epiphyseal height, the metaphyseal density to be increased. The slip position, the displacement of the metaphyses is anterior and superior with a decreased neck shaft angle, and a mild sclerosis is seen, which could be suggestive of a chronic slip. When we draw the cleans line, we see that it does not cross through the epiphyses on the left side, indicating that it is a slip and the Truthoven sign is positive. We calculate the neck shaft angle in the AP views. It is reduced on the affected side, that is the left side. We see the Southwick epiphyseal neck shaft angle on the AP view, and that is also reduced on the left side. And when we calculate for the severity, we see that it is a little over 60 degrees, indicating that it is a severe slip. We calculate the neck shaft angle on the lateral views, but however, since the abduction is limited, it is not a true frog leg lateral view, and calculating the severity on the lateral X-ray is difficult in this case. The articulotrochanteric distance is reduced on the left side. The anatomical proximal femoral angle is reduced on the affected side. We cannot calculate the MMPFA because the scanogram is not available, so mechanical axis cannot be drawn. Now, the limb length discrepancy in this case at present is 2 centimeters. Now, to predict the limb length discrepancy at maturity, we need the magnification factor of the X-ray as well as long limb views, that is the scanogram. And we need to know the physeal closure status of this patient. And since there is a possibility of a contralateral slip, so if that happens in the course of till before maturity, so the limb length discrepancy can change. Now, any child with slip capital femoral epiphysis with open physis will require a surgical treatment. The additional points that we need to consider in this case, we will need a lateral elbow X-ray to determine the status of maturity in order to see whether the physis is approaching closure or has closed already. The BMI of the patient, the endocrine status, in order to estimate the risk and plan for a contralateral prophylactic fixation in this case. Now, the problems that we address, if we leave this patient untreated, there is a chance of further slip, which will require a fixation. There could be a limb length discrepancy. Since at present it is 2 centimeters, we can give a shoe raise, or if it increases, we can go for lengthening. The range of motion is restricted, which might require later proximal femoral osteotomy. A contralateral slip can occur, which will require a prophylactic fixation, and osteoarthritis can occur, which might be addressed via arthroplasty and arthrodesis in future. The treatment options at present, since it is a painless walking patient, we see that the slip is a stable slip. We have two options. We could either go for an in situ pinning or a safe surgical dislocation with capital realignment with modified Dunn's procedure. For in situ pinning, we use a single fully threaded cannulated steel screw, which is placed central in AP and lateral view and perpendicular to the physis, with at least 3 threads crossing the physis, avoiding the joint. Now, the post-surgical complication that we see in this case would be an avascular necrosis or a chondrolysis, a femoral acetabular impingement, a fixation failure or a slip progression, a contralateral slip, osteoarthritis, and in a later stage, if we remove the implant, it could be implant removal difficulty. Now, to address these post-surgical complications for avascular necrosis, we could go for a core decompression or a hinged hip distraction. We could also use a fibular graft, vascular or non-vascular, or we could go for proximal femoral osteotomies. And in some, there has been evidence of use of bisphosphonates in this case. Now, chondrolysis, we can prevent this by the careful pin placement. Femoroacetabular impingement, the CAM type is predicted, and this can be addressed via an osteochondroplasty. And osteoarthritis can be addressed by arthroplasty or an arthrodesis at the later stage. And growth arrest will lead to limb-limb discrepancy. If it remains up to 2 centimeter, it would be shoe raise or a lengthening in with another surgery. And implant removal can be ease off using a fully threaded steel screw, which is much easier to be removed. And the contralateral slip can be addressed via prophylactic fixation of the opposite side. Thank you.
Okay. Well, thank you for a good presentation. But again, like I said previously, Kishmita, in an exam, you got to commit yourself. Like, what is your plan? You gave us 2 plans. So
Sir,
which one are you going with?
Sir, at my stage, since I am still in the learning phase, I will go for an in situ fixation, since safe surgical dislocation has more chances of avascular necrosis. And at my stage, at the learning stage, I don't want to go in such a vast surgery. So I would prefer to stick to in situ fixation in this.
Okay. All right. So one other thing I'll tell you guys. So have you guys heard of J.C. Tarapurwala? He was a super orthopedics surgeon, very well-known educator. I'm not sure. Dhiran bhai, do you know him?
Yeah, yeah,
Did you know him?
Yes, yeah. A
So he
very
used to
jovial
teach-
fellow.
Yes, yes, very, 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 very. So he used to teach us at KEM when I was in Mumbai during my residency. So he used to come every Wednesday and teach us. So he used to teach us a couple of things. One thing is, in the exam is like a tightrope walk. You need to talk a little, you need to talk correctly, and then be precise. So my comments would be like, when you're in an exam situation, don't give too much unnecessary information, because you'll be digging your own grave. Okay, so just restrict yourself to the question that's asked. Okay, so I know you made a nice presentation, lots of complications you listed, but yes, keep that information to yourself, because allow them to ask you a question. So it's like building a house brick by brick. So show them that your thinking is logical, and then let them ask the questions, because if you give them all the information, they don't have anything to ask. They'll ask you more difficult cases. They'll bring up other cases which will be more difficult than this case that you know all this information about. So try to use the information that you have, by talking little precisely and to the point. Okay, so that's what he taught me. So I thought I should pass on that advice that I got from him to you guys. So if you're committing yourself to in situ fixation, then you have to tell the family that he'll require another surgery, because in situ fixation is going to prevent the slip from progressing, but it's not going to alter the natural history of his hip. Okay, so you have to do another osteotomy. So if you chose your first plan, then what is your follow-up plan to that? Because you didn't correct anything by doing an in situ fixation except preventing progression of the slip. So if you're choosing the first option, then you have to say that second option would be, I'll be coming back and doing like an Imhauser or a safe surgical dislocation, and then do an osteochondroplasty because there's lots of impingement there, and then doing an Imhauser, which is a subtrochanteric
Subtrochanteric.
three-dimensional osteotomy to correct external rotation, varus, as well as flexion. So those are the three things that you would require if you choose the first option to do an in situ fixation. I'm not saying it's wrong. It's just that you're further away from the apex of the deformity. So you will have to create like a zigzag deformity to correct that. I've done it, especially in unstable slips. That's what I would do. But in this case, because it's a stable slip, that would not be my preferred option. I know it may be the preferred option for other people, but my preferred option would be a safe surgical dislocation, trochanteric osteotomy, osteochondroplasty, done osteotomy, and then fixing it. That way I can correct everything through this. And then, so that would be the option. As far as you said, this case requires a contralateral slip. The risk of contralateral slip in this case, there's enough information on this pelvis. Yes, getting an X-ray of the elbow and like a bone age X-ray, etc., would help. But you get a lot of information on this. You can use the Oxford bone score here. The triradiate cartilage is closed. Greater trochanteric apophysis is closed. That means it's already, if you draw the puberty diagram of Demiglio, you'll see that it's already in the descending part of the pubertal growth curve. Did you guys know the pubertal growth diagram? I would suggest go and read Demiglio's work. But in this case, this boy is pretty advanced skeletally. The risk of slip is very, very small. So, and the contralateral fixation is not without complications. So in the literature, you can find support either way, but in this case, I don't think the risk of slip is very high on the opposite side. So I would not be doing any contralateral fixation for this guy. If the triradiate cartilage was open, or if the greater trochanteric apophysis was open, you might consider that, especially if the triradiate cartilage was open. Otherwise, no, because in Dallas from Texas Scottish Rite, they published some data which said that if the triradiate cartilage is open, the risk of the contralateral slip is like 70%. And then that's what we use, and the Oxford bone score to determine the likelihood of contralateral slip. So I would not touch the other side, but that would be my plan. Any questions?
Virenbhai, you are making some comment?
Yes, fine. This will look like a very basic comment, but this is very important understanding that when we have this deformity, the first is there is an abnormal geometry. The second, there is a bump, which we call it the bump on the anterior side because of the slip, which is going to cause future osteoarthrosis. So that's the second problem. So when we deal with this as a in situ pinning, we need to remember that we are not doing anything for the bump, and that bump is going to cause problem in the future. So yes, we are just taking care of one problem, that is prevention of the further progress. But that's just a part of the big problem. The second problem is still remaining. And I would suggest that when you answer this in an exam, you need to say that your subsequent program is going to be taking care of that bump, which we call it as a osteochondroplasty. And the third thing is, like already the first slide says that it's minus 25-degree external rotation deformity. That's a very abnormal environment for the hip joint. And for anyone with a minus 25-degree or like external deformity to walk is very difficult. So we need to understand that minus 25-degree or the external rotation deformity makes us very difficult to walk forward because the pelvis cannot come anteriorly. And that would definitely interfere with walking. And subtrochanteric osteotomy has to be taken into consideration for taking care of the abnormal geometry. So that would be my comment to this case.
Yeah, Agreed, Dhiren. Another thing is for lesser degree of slips, you could also consider like in situ fixation with arthroscopic,
Yeah, chopping off that fragment.
arthroscopic osteochondroplasty. And then the other thing is, Parsh has a nice series where for lower degrees of slip, especially if they are unstable, you can do like a limited approach without doing the big surgical dislocation approach to reduce it and then put it back. But for a severe slip like this, especially if it's stable, that would be hard to do, at least in my hands. Yeah. But those are different approaches you can think of. And then there's also like a shooter approach, which is a small anterolateral approach to the anterolateral part of the femoral head and neck area, where you can do a smaller approach to the osteochondroplasty without the big whack of surgical dislocation.
Yeah. Any other question from anybody? Any fellow? Before we conclude, we'll finish because we are overshooted already. But any question?
One
Last
question
question.
I had was, I think Anil Agarwal is there. He's been asking us like, how will you treat caput valgum? Maybe you guys, what would you guys do? Have you done like Ganz's femoral neck osteotomy to correct caput valgum? Hitesh, Dhiren, or even Anil, if you want to unmute yourself and talk to me. So I'm interested in learning myself.
I generally do in case where there is a repeat to the caput valgum. I arrest medial side as well as the varus osteotomy. So that would be the lateral is already arrested. Medial I'll arrest.
Yes.
Along with that, I'll do the varus to get the hip coverage. But the Inho Choi from the Korea has published a very nice paper in BMC Musculoskeletal Research. He said doing about medial epiphysiodesis will not prevent the greater trochanteric overgrowth. So if child is young, I will do the greater trochanteric epiphysiodesis as well.
Yes. Anil, you want to add anything? Anil Agarwal?
Yeah, he's there. You are muted. You are muted. You are muted. Unmute. Yeah.
Yeah.
Anil. Yes.
Yes, sir. Basically, I don't treat so many caput valgum, so I have only limited experience with this. But I have tried few screws, but not much, and I've yet to see the follow-up, sir. I don't have I usually restore to varus osteotomy, that's it in these cases, but no experience with growth modulation for these caput valgum.
Thank you,
No,
Anil.
see, the basic problem is in caput valgum, there is a growth arrest or the reduced growth on the lateral side. Now, doing growth modulation on a medial side will just prevent the progression, will not take care of the correction. So for correction, what Hitesh said is very important, that you need to do a varus osteotomy. And if we add that screw from a medial side, yes, it will prevent subsequent redevelopment of the caput valgum. So we have to combine both the things, osteotomy plus growth modulation.
So Hitesh, when you combine a varus osteotomy in addition to like a subtrochanteric or intertrochanteric osteotomy, how do you fix both the osteotomies? Do you use an additional screw? Or
yes, we'll use the additional screw. Not with we use always additional screw. That is
which osteotomy do you do first? Do you do the femoral neck osteotomy first to correct caput valgum, then the subtrochanteric osteotomy?
No, we'll do the first pass the wire for the caput valgum, then do the osteotomy. So in that same track, we can put about the screw.
So you do the subtrochanteric osteotomy first and then do the femoral neck to correct the caput valgum.
Yeah.
No, Hitesh, like what you are trying to say is like you do two osteotomy or one osteotomy?
No, one osteotomy.
Actually, so that's a confusion. Like it's a one osteotomy and then the screw.
Yeah, one osteotomy.
What do you mean? Can you explain again?
No, we'll do the medial, the growth arrest for the caput valgum. And along with that, we'll correct the coxa valga by the varus osteotomy, subtrochanteric osteotomy.
Okay.
Not like Gens at the neck osteotomy. Don't do the neck osteotomy.
Yeah. But in those in one of the cases it showed there was hardly any medial epiphysis left.
Yeah, in medial epiphysis left, just then it will not be. Once we get the varus, we'll get about the configuration much better. The same case we have done it. I can share with you that case. Same case is having long follow-up. She's skeletally mature now. So it's okay.
Good. Yeah.
Thank you very much, Dhiren bhai. You can pass a lot of thanks. We already over, so then he wanted. Sorry, I'm very sorry.
Yeah, thank you, Mohan, for sparing time for us. Like we know that we discussed about this session in July, but actually it happened in December. But I know that in spite of your busyness, you decided to spare time for our fellows. And this is very important discussion because the basic understanding of the problem is very important. And this exactly goes with the concept of active learning. It's not only the lecture and one-way discussion, but basically two-way interaction. And I'm sure that our fellows are going to remember this session for a long time. And thank you once again. And I wish everyone a happy New Year. And again, we have a next session on 16th of January. Dr. Jason Howard from USA is again going to speak on neuromuscular foot problem, the management. So we will share that information. Till then, have a great time with your family. Thank you. Thank you, Mohan, once again.
Thank you very much.
Yeah.
Bye.
Bye.